Hello, I am Deborah, author of the Baravage Parallel series, Reflections on the Decline of Belief in Science and Religion. I am holding discussions based on the topics covered in the series with notable experts, which brings me to our guest, Dr. Adam Fox. Now, without further ado, Dr. Fox, please do introduce yourself.
Well, I'm Adam Fox. I'm delighted to be joining you here. I'm a professor of paediatric allergy at King's College London. I guess my day job is as a consultant paediatric allergist, seeing children with a whole range of allergic diseases. And I've also been the president of the British Society for Allergy and Clinical Immunology, which is essentially the representative society for allergy specialists. And having just finished that role, I now chair something called the National Allergy Strategy Group. So that's essentially a collaborative of the British Society together with allergy charities like Allergy UK, Anaphylaxis UK, the Natasha Allergy Research Foundation, coming together and lobbying government for better provision of allergy services, and also looking at ways of informing policy across the whole range of different things to improve the life of allergy sufferers. So thinking about food labelling, how allergies managed in school, on aeroplanes, things like that.
That's wonderful. Thank you so much. Just to make sure everyone is on the same page, I think it would be really great to define what an allergy is and how it distinguishes itself from something like an intolerance.
It's a great place to start because this field is littered with misconceptions. And I think one of the fundamental ones is people really not understanding what we're even talking about when we think about allergies specifically. So I think probably the easiest place to start is thinking about food allergies. Everybody hears about peanut allergies and allergies to milk, things like that. Lots of bad things can happen when you eat something. Now, that umbrella term for that would be adverse reactions to food. And within that, there's things like toxic reactions. So, for example, if you eat a sandwich, the chicken sandwich that's been out the fridge for a few days, whoever eats it, they're going to get sick. So that's a toxic reaction. It affects everybody. But then there's a whole raft of non-toxic reactions where essentially one person could eat that food and it would be absolutely fine, where somebody else could eat it and it could be potentially life-threatening. And we can then divide those non-toxic reactions into two sorts. Those that involve your immune system, and those are food allergies, and those that are still reproducible and they're very much real, but they don't involve an immune response from your body. They're what we refer to as food intolerances. And the most common of those would be lactose intolerance, affects the majority of the human population in adulthood and certainly all other mammalian species. And essentially those the guts of all mammals, with the exception of a few, usually Caucasian humans who have got a genetic mutation, they don't have the enzyme that breaks down the sugar in milk very well. So in adulthood, they'll find that if they have large amounts of lactose in plain milk, for example, they'll get upset tummies and bloating, windiness, things like that. So that's the intolerance. Your immune system is not involved and distinct from those reactions where it is. So what's actually happening with your immune system is that your immune system is getting confused and making a mistake. And instead of ignoring something that it should know is harmless, whether it's a pollen grain or a peanut butter sandwich, those things instead elicit an inappropriate immune response. And that immune response can be potentially harmful to the individual who's responding in that way. And I think often there's a lot of confusion. People often talk about the immune system getting it wrong and responding as though it's something dangerous, so as though it's a bacteria or a virus. But actually, that's not the case. It's actually a completely distinct type of immune response that's not the same as ignoring something, what we call tolerance, which is what should happen when you eat something or breathe in a house dust mite or a pollen grain. It's not the same as the immune response that we get to dangerous things like viruses and bacteria. It's a separate response. The Latin name is atopy, and that's often how we refer to it medically. So people who have got a tendency to getting allergies, we refer to them as atopic.
Right, that makes a lot of sense. Thank you so much for that. What causes someone to be allergic to something? Could it be genetics, types of exposure? How does that work principally?
It's a range of things coming together. So if you look back at allergy in history, you can find cases, but they were really, really rare. So one of the Roman emperors, Britannicus, clearly from the descriptions was allergic to horses, and he would break out in hives when he went riding. There's other examples, even from Claudius Galen, so we're really going back thousands of years now. He reported episodes of people having allergic reactions, but it's only really over the last 70 or 80 years that we're starting to see lots of it. Jonathan Bostock, who was a paediatrician, described his own hay fever in the Lancet in the early part of the 19th century. It took him 9 years to find another 20 or so cases to write up alongside his. So we're talking about something that's changed profoundly in a very short period of time. And that's the first big clue that this isn't just about genetics, because genetics are never going to change that quickly in a short period of time. But there's always been people around who have had that atopic tendencies. They've had the right genes, but something has changed in the environment that has meant that all of these atopic people, and we know that, for example, 25% of the adult UK population get hay fever. So by definition, they are atopic. So there's been this sort of large, latent, genetically predisposed group, but something has happened in our environment that's meant that they're now all showing themselves and their allergic disease is manifesting itself. Now, the sort of prevailing theory for a long time was the hygiene hypothesis, also known as the clean child theory. So this was an idea that came up in the 1980s, and it was from epidemiological studies showing that it appeared that if you were the first child in your family, you were more likely to get hay fever. So the theory then sort of expands this idea that if you're the firstborn child, there's no other kids bringing home germs and bacteria. So your environment in the more modern world is a little bit more sterile. Your immune system isn't stimulated in the way that it is used to being. And consequently, it starts developing inappropriate responses to things it should otherwise be ignoring. Whereas the younger children in the family, they've got older siblings bringing home bugs and germs from nursery and the outside world. There's more pressure on the immune system of that younger child, and consequently their immune system develops more quickly, matures more appropriately, and responds as it should and doesn't develop allergies. Great idea, huge holes in the theory, especially the fact that data relating to this birth order effect were very inconsistent. And in fact, in lots of epidemiological studies, it just didn't exist, this effect. And of course, you only have to look around the world and look at what the rates of allergy are. And there's good studies looking at this. And you would expect that in environments where children were placed under less immunological pressure, so for example, environments where infant mortality was very, very low, you would get very high rates of allergy, but you don't. And places like Switzerland, good example of somewhere where very low infant mortality, but actually not particularly high allergy rates. But when you do start looking at where gets lots of allergy, something cultural starts emerging. And if you look at those sort of, the world leaders in allergic disease, it's the UK, Australia, New Zealand, Canada, United States. There is clearly a cultural thread that's running across all of this. And then you start looking a little bit more closer at, well, what could those other environmental changes be? And then we start focusing on, I think we're right here, on the gut microbiome. So this is a huge area of science, very exciting area of science, but one that's very much in its infancy of our understanding. But we know that we are colonized by trillions of bacteria in our guts, that a huge range of things will influence what those bacteria are and which are the dominant species that colonize us. They produce different chemicals and provide a different environment in our gut depending on which species are predominant there. And those chemicals will influence the way that our immune system interacts with the outside world. It has a really profound effect on that. And more recently, people have started talking about the old friends theories, this idea that we've developed these really effective, synergistic, symbiotic relationships with the bugs that coexist in our gut. And that when there's a disturbance of that, that's when we start seeing these bad things happening. And in fact, I think it's becoming pretty clear that if you have a much less diverse group of bugs colonizing your gut, it seems to predispose you to getting allergic disorders. But of course, you've then got to throw into that mix the genetics and a genetic predisposition. And then on top of that, certain exposures that then predispose you to getting particular allergic conditions. So as you can, imagine, this model is now getting very complex. But if you've got the wrong sort of genes, and you're unfortunate enough because of environmental changes that your gut microbiome starts nudging you towards expressing that allergic tendency, then there's more of a likelihood that if you come across certain triggers that you'll then develop allergies.
That makes a lot of sense. And I think also when we talk about the gut microbiome, it's become a little bit of a sort of a push word, perhaps. Online, there's lots of misinformation about it, perhaps principally because there's a lot we're still learning, we're still picking up so much information. And so it's very important for people to exercise that discretion when they're looking up online about the gut microbiome. And it's just perhaps a disclaimer to say that when we're talking about the gut microbiome, we're not referring to perhaps some of the things one might come across online, and eating certain things or doing certain things is not necessarily going to make you magically healthier or otherwise.
I admire your lack of cynicism, but the reality of it is that sadly, because it's a incredibly complex science that's just in its infancy, it's hugely at risk of being hijacked by people for their own commercial gain. And there's all sorts of crazy stuff out there online encouraging you to. And in fact, I think one of the threads through the misinformation will be often people who aren't licensed practitioners. They're not able to prescribe medicine, so the only way that they can offer an intervention is through diet. And of course, for that business model, this is hugely helpful for them because they're able to say, look, if I tell you the right things to eat, I can make you healthier. Now, that's not to say that there isn't some, there's a lot for us to learn about nutrition and how that can hugely alter health outcomes. And allergy is certainly one of those areas. We've seen a massive change in our understanding of allergy prevention through, for example, early introduction of allergenic foods in the infant weaning diet. But it's not a panacea. And your gut microbiome doesn't control your risk of everything. And, you can eat all the right things, everything, see all the right podcasts and do all those, follow all of that advice. And there are some people who, and I see this in my practice all the time, they get allergies anyway, because sometimes the genetic predisposition is so strong.
And I think also if anyone is suggesting there's something wrong with your gut microbiome and that's fixed by something they sell, probably ignore it.
Absolutely.
That a lot of people in my age group, particularly, so I'm Gen Z, a lot of people in my age group have allergies. I'm one of those 2000s kids, born in 1998. By 2000, I'm a patient as well. Why is my age group so prone? It's a very
Yeah.
ambiguous question, I
It's,
know.
it's it's a fascinating area, and sort of I've sort of my professional career has gone alongside this huge growth. And if you go back to the 60s and 70s, there was a very significant increase in the amount of respiratory allergy and asthma, and then that sort of peaked in the 90s really and sort of settled down. And what we haven't seen beyond that is a continued increase. So if we were on the trajectory we were in the 80s and 90s, we'd all be allergic, we'd all have asthma by now. But we don't. It's settled at around 20% of the UK population. And there was also a marked increase in the amount of eczema and other allergic disease, or at least a disease with a significant allergic component to it. But what we really saw change through the 90s and the 2000s was the rates of food allergy. And there were some lovely studies that were able to illustrate this really very, very powerfully. And one of those were a group of studies that took place on the Isle of Wight. Now, on the Isle of Wight, you've got quite a static population. It doesn't, you study anything in London, for example, and half the people that you saw 10 years ago have moved on and gone somewhere else, and a different group of people have moved in. The Isle of Wight's a really good population to study because it sort of stays put. It's very, very well geographically defined, and they have an excellent allergy research centre on the island. So they're able to look at essentially every child born on that island through the 90s and the 2000s and do all the questionnaires, but not just the questionnaires, because that generally over perceives food allergy. If you just ask people if they're allergic, more people than genuinely are say yes. But they're also able to do allergy testing and the definitive tests of bringing kids into the clinic and saying, well, you've got a positive allergy test, but what happens when we give you this food? So you get an absolute answer. And they essentially identified two epidemics: an epidemic of genuine food allergy that affected about 5% of children, and an epidemic of perceived food allergy that affected about 33% of children. So there was clearly an issue of people developing a tendency, as we saw food allergy grow, a tendency for parents to ascribe their child's symptoms to food allergy, when more often than not it wasn't. Only about 1 in 12 of the kids that the parents thought had an allergy did, but actually a genuine epidemic. So we're talking about 5% of kids in the UK with a food allergy. I mean, I recall, being at school in the 70s and the early 80s, there were 1,500 kids at my school, and there was one kid with a peanut allergy. That, and that was considered really unusual and a really strange and exotic thing for somebody to have. Whereas now we're talking about every classroom having a child with a food allergy in. Now, that rate of increase doesn't seem to have continued. I think there's still a bit of a prevailing sense of we're still in the midst of this food allergy epidemic, and that there's more and more kids. And interestingly, if you look at the rates of presentations to emergency departments with significant allergic reactions, there does seem to be an ongoing trend upwards. And in fact, year on year over the last 20 years, that's grown in the UK by about 6 or 7%. So really, really significant increases. But that's of children presenting to A&E departments. We've seen similar data from Australia, from Europe, from the US. But if you actually drill down into, but does this mean that there are more children with food allergy, or does it mean that there's more likelihood that when a child has a reaction, it's taken seriously and it presents to an emergency department? It seems to be more the latter, because recently the European Academy of Allergy, it's the sort of the big learned society in Europe, did a systematic review of prevalence studies of allergies and showed that actually there doesn't seem to have been any meaningful increase in the number of people reporting food allergies over the last 10 years. So we've sort of reached that, or appear to have reached that plateau in the way that asthma did, but it's a high plateau. You're talking about, after eczema and asthma, food allergy being broadly the most common chronic disease of childhood. Now, we know that lots of children outgrow their food allergies, classically if they've got allergies to milk, egg, soy, wheat, and those are common food allergies. But we also know that the children who have got allergies to nuts and sesame and peanut, fish, shellfish, they much less commonly outgrow it. So we do have this emerging and growing cohort of adults who were the children in your Gen Z, the children in the 90s and the 2000s who were part of this increasing wave of food allergies, who are now getting older, they're adults, they're not outgrowing their food allergies. And in fact, recent estimates, whereas conventional wisdom was that only about 1% of adults had food allergies, that's just wrong. And more recent studies suggest it's much closer to the 4 or 5% that you see in kids now.
I think that's such an interesting point. I think with penicillin, particularly, we saw a lot of people, and perhaps still do, see and meet a lot of people that say they're allergic to penicillin, but perhaps there's no concrete evidence for that. People sort of may prefer amoxicillin, assuming that it could generate an allergic reaction. And there are certainly people who will have a strange reaction to something on one instance and perhaps assume, oh my gosh, I must have an allergy, I've heard of this, that must be what this is. And it's always worth looking into, although of course if somebody's struggling to breathe, etc., then A&E is recommended. But I wonder, from the perspective of those who are my age now, like you say, with allergies that they haven't grown out of, and I've got some things here, so it's a bit more interactive than some of my other interviews that I've done before, because I think it's really useful. So here there's 2 asthma inhalers that I've got, for example. This is a salbutamol. I won't go into the brand names. Actually, I might do. Foster, which I know is half steroid and half...
That's a brand, yeah.
And I think the brown steroid it's usually a clenil modulitis.
Yes, that's right, or a purple one, yeah, a preventer.
Gotcha. So with regard to these, now, there's a lot of people with allergies, food allergies, who are walking around with asthma inhalers. Plenty, and this isn't actually a steroid cream, but an example, they may be having eczema as well. And we know that these are comorbidities. How do these conditions link? Because we're seeing steroid creams and steroid inhalers and steroids in A&E for anaphylaxis. So how do these issues link, and why are steroids so helpful in every case?
Wow, a lot to unpack there. But yeah, there's for me the fascinating thing about allergic disease is the way that it's what we call multi-systemic. It's rarely about just one thing. If you look at children who have got those allergic genes, that atopic tendency, often the first manifestation of allergic disease will be eczema in early childhood, often in the first few months of life. And you only need to spend about half an hour in an allergy clinic before it becomes apparent that the children who have got eczema in early infancy, and the worse their eczema is and the earlier their eczema started, the more likely they are to get a food allergy. Now, that was always understood as an association. What we now understand is it's a causal association. That because of the way that you become allergic to food, it's because of the eczema that you're more at risk. And likewise, the worse your eczema is, the earlier you start, the more the likelihood of those food allergies develop. And I don't want to focus too much on this, but essentially, our understanding now of how you become allergic to peanut, that's the best studied model, is that it's all about exposure through the skin when you're little, before your immune system has seen peanut in the gut, where it normally would see food for the first time, and learn that it's food and it needs to be ignored, and there should be immunological tolerance. So essentially, your immune system ignores it. But instead, what's happening in children who have got eczema, which means the immune system of their skin, which sits just below the skin barrier. And remember, if you've got genetically programmed eczema, then your skin barrier is not going to be working very well. It's essentially leaky. Then the immune system that's underneath what should be an impervious barrier, but instead is a leaky barrier, gets to see what gets onto the infant's skin. And that will include peanut, sesame, a number of things that parents have eaten, and then they kiss and touch their infants. Now, if the first place that your immune system sees that peanut protein is through the immune system in the skin underneath an inflamed and angry eczematous skin barrier, then there is a really high chance that that immune system will make a bad decision. And rather than saying this is a food protein, because remember, it's not seeing it in the gut where it expects to see food, and it's the immune system in that child's gut's never seen peanut. So there's no message to say, don't worry, ignore this. Instead, you get that inappropriate allergic response. So there is not just an association between eczema and food allergy, it is a causal association. And then over time, those children with eczema and food allergies are much more likely to get respiratory allergy. Now, that could be hay fever, could be a dust mite allergy, it could be asthma. And to give you a sort of sense of scale of effect, if you've got eczema and egg allergy as an infant, your risk of getting asthma is 80%, sky high. It's unusual for you not to. If you've got nut allergies, your risk of asthma is 75%. But then likewise, between respiratory allergies, nearly all infants who have got positive test at dust mites when they're little, nearly all of them will go on to get asthma. Most people with asthma will have hay fever. Certainly the majority of people with hay fever will go on to get asthma. All of these things are closely interlinked. And making it even more sort of fascinating is that if you've got asthma that's not well controlled, you're much more likely, were you to eat the food that you're allergic to have a more severe reaction. And it's hard to control your asthma if you're not controlling your hay fever properly. And in fact, rhinitis, inflammation in your upper airway because of something like hay fever, is one of the most common reasons why your asthma will flare up. So you simply can't disentangle these conditions, both in their underlying cause and also their management. And if you do, and remember, the British medical system is systems-based. So if you're a pretty average severe allergic child, you'll be seeing the dermatologist for your eczema. You'll be seeing the respiratory physician about your asthma. You'll be seeing an ENT doctor about your hay fever and rhinitis. You'll be seeing a gastro or maybe a general pediatrician about your food allergies. And there's a chance that all of those doctors will be giving that child steroid for a different part of their body. Steroid creams for their eczema, a steroid nasal spray for their rhinitis, a steroid inhaler for their asthma, and so on. So there's a real risk of steroid loading because nobody's taking holistic care of these kids. And this is essentially the reason why you have allergy doctors. And I got into this field because when I was doing my training, I was going around all these clinics and I was seeing the same kids showing up in different clinics in the same hospital. In fact, what I found myself when I was started to help out in the dermatology clinic and the respiratory clinic, I was having to refer these children to see myself in a different clinic in order to do the basic tests to manage that child holistically. Whereas if we get kids coming into an allergy specialty clinic, we're able to assess all of that together in its entirety and make sure that we're not unnecessarily treating asthma when actually the problem is that the rhinitis is not well controlled and that they don't need a puffer, they need a nasal spray, and then actually everything gets better. And that we can manage their food allergy in the context of their coexistent comorbid asthma and rhinitis. All of these things need to be done together. And sadly, the UK's really dragged behind on this. And whereas in France, Germany, Spain, there's about 1,500 or so pediatric allergists, similar number of adult allergists. In the UK, we're still sort of in double digits for the number of specialists that we've got. So we've got a long way to go to do well by these kids and push back against the fragmented care that they get, because allergy is a package, it's not a single disease.
That's a very intriguing point to me. I'm thinking back through my own experiences, and it was very well collated. I was very lucky. I did have the asthma and allergies, but I was seen at the same clinic. Addenbrooke's are an incredible trust. I mean, and just an incredible
And a good example of early pioneers of specialty allergy. Sadly, that's an unusual experience. It's not the norm. And in fact, whilst there's a number of big specialist allergy services, particularly in the southeast, and Addenbrooke's is sort of the northern outpost of that, beyond that, they become far fewer, further and fewer between. And there's some sort of pretty much sort of deserted areas when it comes to specialty allergy in the southwest in Scotland, where there's a huge burden of disease and very small number of very dedicated people doing their best to manage a completely unreasonable patient load. This we often talk about the allergic or the atopic march, which is this progression of conditions. And if we sort of went back to sort of planning healthcare services on a blank piece of paper, it would make no sense to send these kids through all of these diverse routes to try and get their overall management done. It makes far more sense to sort of support them through this package of diseases that will so commonly affect them.
And that makes total sense as well, because I'm thinking if you're experiencing, and of course asthma can so severely affect your allergies. If you don't have the lung capacity even that you could potentially have because your asthma's out of control, and then you eat something you're allergic to. I mean, the danger is immeasurable. And if you feel that you are being dealt with in such a fragmented form, I can imagine that's quite distressing if one area is getting worse and you know it's the principal issue, but perhaps you're not being seen for that for a good while, and you're seeing someone else who's trying to manage that situation. It sounds a bit like a sink filling with water and pulling the plug out, but nobody finding the tap.
Yeah, that's a very good analogy, and we often refer to something called the allergic seesaw. So this tendency that if your asthma's calming down, that your eczema will flare up, and if that calms down, something else will flare up. And so trying to sort of manage this, and as well our sort of NHS obsession with these regular reviews that aren't when the person needs to see a doctor, they're often when whatever the problem was has settled down again, means that we have a very unresponsive system. For people who can be flaring, it will be sod's law. They'll end up seeing the dermatologist when their asthma's flared up, and by the time their asthma's settled down and they see the respiratory guy, their problems, their eczema. So, we can do a much better job of managing kids with this group of conditions for sure.
Absolutely, and I think that must also give, because often it is children in this position, it must give parents so much more peace of mind if they can be dealt with in one. Because I remember what it was like for my parents. Sometimes they write things down, there's a few different things going on, and they really need to speak about each one and get through it. It can be so difficult if you don't feel you can really just offload that to a doctor that can handle all of those things at once,
Yeah.
and have equipment and etc. to
But
help.
also the lost opportunity around, for example, allergy prevention. So because we can almost spot the kids who are most at risk of getting food allergy because of their early onset and severe eczema. And there's now very nice randomized control studies demonstrating that if you aggressively manage that eczema early on, you can reduce the likelihood of food allergy developing. We also know that there's strategies around early introduction of allergenic foods into the diet as a way of massively reducing the risk of allergy developing. But you can only do that when you've got access to the tests and are immediately able to act on those results. So bringing together those skills to manage severe eczema from the dermatology clinics with the skills from the dietitians and the allergy doctors around managing diets in early infancy and those kids most at risk can make a huge difference to long-term outcomes. If you can get it all right in the first few months of life, and you can markedly reduce the chance of that child having what would then become a lifelong condition that almost certainly also increases their risks of other subsequent conditions as well. It makes so much more sense to be very focused on that early part of life when we know the immune system is just starting to develop what will then become a pattern that's laid out for the rest of that child's life.
That makes perfect sense. In terms of the allergies that are particularly severe, anaphylactic shock principally, I think people find it a bit confusing. In the media, there is perhaps not a stigma, but a stereotype of the person who clasps their throat, goes very red, swells up into a big ball, and it's directly after they ate something. It's nice and clear. It doesn't necessarily include an airborne situation. How can we know that someone is having anaphylaxis and not a heart attack, stroke, or other immediate emergency?
So the context is hugely important. And I would say that in the overwhelming majority of cases, with that context, it is pretty clear what's going on. And I think the other thing to be clear about is that episodes of anaphylaxis are usually, for want of a better word, less exciting than you would imagine. They're not these sort of sudden sort of collapse and clutching at throats at all. And in clinics, we actually induce anaphylaxis not infrequently. When we're not sure if somebody's allergic to something, we give them some, see what happens. And from time to time, the reactions won't be mild, they'll be more significant. And so we get to see a lot of anaphylaxis in that context. We also do a lot of work around desensitization, where we deliberately give children small but increasing amounts of a food they're allergic to build their tolerance. And sometimes that causes anaphylaxis. And so typically it would be in a child who knows that they have, or a person that knows they have a food allergy that's just eaten, who will typically get early symptoms very rapidly of itchiness around the mouth, maybe some swelling, hives, all of which are very, very typical allergy features. But that reaction rapidly progresses to features that involve either their breathing, so either persistent coughing, starting to notice that their chest is feeling tight, and then eventually getting wheezy or having very noisy breathing because of swelling in their upper airway. Or there could be signs of circulatory issues. So that would typically be feeling lightheaded or dizzy, or what often patients describe a sense of impending doom. They know something really bad is happening. But they're able to communicate that in the vast majority of cases. And whilst these things can progress quickly, it's not so quickly that you can't see that there is an evolving picture, all of which together, particularly in the context of somebody with allergies. Of course, there won't always be known to be somebody with allergies, but there usually be the symptoms of the itchiness and the swelling and the hives. It's enough to be clear, okay, what's happening here is a severe allergic reaction. Now, a few things to get straight. So the first is that fatal anaphylaxis is really, really rare. So even amongst food allergic individuals, the likelihood of them having a fatal anaphylaxis is still significantly less than them, for example, being in a car accident or dying from any number of other causes. It's not quite a 1 in a million amongst food allergic people, but it's still a very rare event. The overwhelming majority of anaphylaxis, when it happens, is actually self-limiting and relatively mild. And what I mean by self-limiting is that if you don't do anything, they will spontaneously get better. I think there's a little bit of a misconception that if you're having an anaphylaxis, it's 50-50 whether you live or die. It's not. However, if you have adrenaline, and the reason we give adrenaline out is it works way better if it's given very early on in the evolution of a severe allergic reaction, then that will almost always snap them out of it and reverse the key things that are happening, which are tightening of their airways and a relaxing of their blood vessels, which leads to a drop in their blood pressure. And what adrenaline does very effectively and quickly is it forces your airways open and it tightens up your blood vessels so that your blood pressure goes back up. Now, as I said, without adrenaline, most severe reactions get better, but you don't want to wait and find out whether you were one of the unlucky ones that wasn't going to. But adrenaline very, very effectively addresses what's going on in anaphylaxis. So having adrenaline available is hugely helpful because it's a very, very, very safe drug. And if you're not sure if a reaction is bad enough, we always say to our patients, this is the signs of an anaphylaxis, and at the first signs of anaphylaxis, whether it's your breathing, your airway, or your circulatory, any of those things, use adrenaline. If you're not sure if your reaction is bad enough, that's when you should be using it, because there's really no downside. You can't be sorry that you used the adrenaline when you didn't really need it. You'll still feel better. But if you don't use it when you did need to, there is a risk of you having a progressive reaction that can potentially be catastrophic. Now, there's always exceptions, and very, very rarely there'll be severe reactions that happen very quickly, and even with adrenaline, still have bad outcomes, but those are extremely rare. For the vast majority of significant reactions, when they happen, adrenaline is very effective. We still recommend that you get emergency help and call an ambulance anyway. But the priority of somebody, if you suspect somebody's having a bad allergic reaction, first priority always is getting the adrenaline in.
That makes a lot of sense. And here's some I prepared earlier.
You're going to show me an EpiPen, aren't you? Yeah.
Yes. Um, Not exactly a new thing for you to see, really.
No.
But for those who are interested, I, for example, will always carry a bag, and that bag has medicines in, and I can throw that bag into any bag that I'm going out with, which makes a lot of sense, and a lot of allergy sufferers will do the same thing. So the EpiPen comes in its own little case, and it just falls out like so. But I'm not going to do any more with that because that's mine and I need it. Instead, the NHS are very, very kind in offering people with allergies these interesting kits. And inside these kits is what's known as a trainer EpiPen. And I'm going to show briefly how that works. I think because the recorded Zoom works a certain way, if you speak while I do the demonstration won't be visible because it will focus on your face. So I may have to go through it first, and then if you give a further description of what's going on. So I won't explain why, I'll just say what I'm doing and demonstrate. So here is an EpiPen. This has a safety, so if you imagine a bit like a grenade, you need to take the pin out. At the top there is a flat part, and the safety comes off like so, making sure that you hold it more like a hammer than anything else, just in case you got the wrong end. And essentially it goes through clothing, so maybe avoid seams, but you want to give it a little bit of distance and then go in till it clicks, and hold it in, don't take it out straight away and spray everybody else with epinephrine. And then you would hold this in for about 10 seconds, it depends, they all work differently, but perhaps 10 seconds is best. Then you would release and massage the area for a few seconds, and ideally have the person sitting or laying down, perhaps particularly if they're feeling a bit faint, but maybe sitting up if they're not breathing too well. I think that should be correct. I'll find out now.
Yeah. Lovely demonstration, spot on. So a couple of things. People do get understandably anxious and confused when they're having to use them. So always make sure you know how to use it beforehand, and you're not reading the instructions when you're having anaphylaxis, or someone you're with is having it. That's not a great time to be learning new skills. So we often talk about blue to the sky and orange to the thigh as a reminder to make sure that you put it in the wrong way, because the most common mistake that we see being made is that people, rather than, as you said, holding it like a hammer, they put their thumb over the end, and if they've then got the wrong end, that needle will go through their thumb and out the other end, and not where, and that's less of a worry about than the fact that there's somebody who needs adrenaline and they're not getting it because it's been used inappropriately. Position is really important, and it's worth a mention because actually it's up there with getting on with doing the adrenaline first. So we always recommend that ideally you want to lie the patient down and raise their legs, so you're thinking about supporting their blood pressure. If they're uncomfortable in that, and if they're having difficulty with their breathing, they will prefer to sit up, and that's absolutely fine. But what you really mustn't be doing is moving them around, trying to stand them up, getting them to somewhere else. You bring the EpiPen to them, not them to the EpiPen. And the reason is that studies of episodes of very severe and fatal anaphylaxis have shown that standing patients up and trying to move them around has a huge impact on their failing ability to maintain their blood pressure. And you can end up with what's called empty ventricle syndrome. So even though the heart's trying really hard, it just doesn't have the oomph to get the blood back up to where it needs to be. And consequently, you get a bad outcome. You're absolutely right that once you've given the injection, it should go over clothes. That's fine. They were, military issue. They're designed to go through combat fatigues, but avoid seams. Make sure it's a nice fleshy part of the leg, as you said, 2/3 of the way down. Some people prefer to place it on the area they want to inject and just press. Others will do the swing and jab, which is what's on the side of the device, although in a device in a different country will have the other method on it. If it's an EpiPen, then it's 3 seconds you hold it. If it's a Jext, which is the other brand that's available, it's 10 seconds. If you're not sure, hold it for 10. There's no problem doing that. Give it a good rub afterwards. Another really, really important thing is if things are not clearly better within 5 minutes, then you should be using your second device, and ideally do that on the other leg. Usually by the time, we always recommend, and the MHRA recommends, that you carry 2 devices. By the time you need a third, you'd like to think that help would have got to you wherever you are, because at the same time as laying the patient down and using the EpiPen, you should be making sure somebody's off calling an ambulance, so that somebody's there to pick things up.
That makes sense, and hopefully that was as clear to people as possible that anaphylaxis is not something that is horribly nuanced and impossible to spot, and often the person is more likely to know that they might have a food allergy or an airborne allergy, so they may also recognize for themselves and communicate to others or to 999 that they're having that issue. And we've gone through the trainer pen, how it works, and also some extra advice from you about making sure that we monitor somebody's blood pressure, or maintain somebody's blood pressure by keeping them laying down or just sitting quietly, as opposed to getting up, running around, and having more issues as a result. One of the things I think would be very interesting to talk about at the end is about managing allergy. When you have it, particularly as an adult, and you know you're not growing out of it, you're going into the world, living life. Obviously, there are different options: cetirizine, hydrochloride, chlorphenamine, and etc. Which do you prefer? Do you think one is stronger than the other? Do you think that with Piriton's ability to be very drowsy, perhaps people don't prefer it as much as they like Pirites, although it's very known for hay fever? What do you think about that? What would be your top advice to someone who is in my age group, going out and living an independent life now? What would be your advice?
So there's essentially two different ways available now for us to manage food allergies. So the first and the conventional way, and very much standard of care, is carefully avoid the thing that you're allergic to. And that includes having good understanding of food labeling, being able to communicate your allergy when you go to a restaurant, when you're out. Those things are really important skills. But sometimes, despite anybody's best efforts, there's cross-contamination, mistakes happen, miscommunications. Having a very clear plan of how you're going to recognize and deal with an allergic reaction when it happens. And when you have an allergic reaction, essentially you need to just think about one sort of basic thing. Is this a mild reaction, in which case I'm going to manage this with antihistamines? Or is this a severe reaction, in which case you're not going to think about antihistamines at all, you're going to go straight to adrenaline? And that's really, really important, because a lot of people, their understanding is that if you've got a reaction that's quite severe, you should try your antihistamines first. And then if they don't work, use your adrenaline. And that's absolutely not the case at all. As soon as there is any sign that it's a severe reaction, any sort of breathing or circulatory issues, get on and use the adrenaline. It's the only thing that will make a difference. Antihistamines provide symptomatic relief for mild symptoms. They don't stop the progress of a severe reaction. So if you think your worsening reaction is going to get better and not progress because of your antihistamines, if it didn't, it was because it wasn't going to in the first place. All it's done is made you less itchy. So antihistamines have no place in the management. They're not on the algorithm for the management of severe reactions. However, if you do have a mild reaction, it's good to have the right medication. And what you really want is something that's going to work quickly and effectively. I don't think there's any place for Piriton or chlorphenamine or essentially the first generation old-fashioned antihistamines in any child under the age of, other than infants under the age of 1, where the other medicines aren't licensed. So if you're a teenager and you've got Piriton, throw it away, get some cetirizine. It's over the counter. And that would always be my first choice. It's a second generation antihistamine. It works just as quickly as the Piriton ever would have done, but it doesn't have the drowsy side effects, except for a very small minority of people. So the problem is that if you're having a potentially significant reaction and you take something like Piriton and then you're drowsy, which can potentially be a sign of a severe reaction and anaphylaxis, you don't really know whether it's the reaction or the medicine you've just taken. So that's not helpful. So no place for it with hay fever, with severe reactions, anything like that, throw it away. Cetirizine is fine for hay fever, but it's also entirely appropriate for managing food allergic reactions when there aren't signs of an anaphylaxis. But don't forget, even the suspicion of anaphylaxis, just get on and use your adrenaline.
Makes a lot of sense. My final question to you is very nuanced and very specific to allergy sufferers themselves. Particularly if you've had an allergy from very young, you go through the period of, oh yes, I must avoid these things or it makes me sick and I know I've got to do that. And then there comes this phase, and I certainly experienced it and other people in my age group have, where you then become aware of really what this is, how serious it could be, and it can lead to instances or periods of time of food avoidance or being afraid to eat at certain places. And there's this real line between living life, going out and doing what you need to do in your life, and also managing the anxiety that actually can be slightly more magnified than the allergy itself. I wonder what your advice would be.
Yeah, I mean, the first is that this is an extraordinarily common scenario. I see a huge number of teenagers. I've often known them for a long time, and you see this emerging over time. In my mind, one of the biggest contributors to this is misinformation. And that will be misinformation about risk, particularly. And I always, when I first diagnose a child, often it's often an infant, so it's really the parents that you're talking to. I spend a lot of time talking about putting the risk of food allergy in context, because if they get off on the wrong foot, if they glean the knowledge about, that what their understanding of risk off social media or newspapers, they're going to have a very, very tough existence, and they're going to end up not traveling, not eating out, not doing any of the things that are all a very, very important and normal part of social development. And when schools get hold of the misinformation, they end up isolating and excluding children from normal activities because of their food allergies when it's just not necessary. There's thank goodness there's now a huge movement led, it's led by parents of people with food allergies and their kids who have had the experiences themselves around better inclusivity in places like school, because if with a little bit of effort, it's absolutely doable. But the reason I'm talking about that risk side of things is because once people realize that actually, yes, there is a risk of severe reactions, but that risk is just up there with road safety, and all the other risks that all of us face every day. And in fact, Imperial College published a paper showing very clearly that if you have food allergy, you are still more likely to be murdered and die in a fire than you are to die of your food allergy, which I think most people find extremely surprising. Now, that doesn't mean that food allergy isn't going to be an enormous monumental pain in the backside in terms of your day-to-day living, but it's really important that you get that risk in context and know that if you carry your adrenaline, if you're sensible about speaking up in restaurants, learning all you need to around food labeling, etc., you'll be fine. Yeah. Of course, there are incredibly rare occasions where things still go wrong, and thankfully, for the vast majority of those, adrenaline will be your best friend and will be the parachute that you need. And unfortunately, there's no accounting for the tiny number of absolutely tragic episodes that happen when things really do go wrong. And when you get involved with those, and I, get involved as an expert witness from time to time in these and at inquests, there's almost invariably a catalogue of errors that have happened. And you can imagine how if just one of those things hadn't have happened in the way that it just did on that one occasion, the outcome would have been different. But there are also really, really important threads that run through the stories that we hear all the time at inquests. And those are areas that it's really valuable to focus on to minimize the risk of further episodes. The first is about asthma control, because we know that having poorly controlled asthma is a major risk factor for having more severe reactions. So if you make sure that, if there is any asthma that's not being adequately treated, that you are, and that, teenagers aren't often the best at taking their medication regularly, but understanding how important it is that they do. And the other is around adrenaline, about making sure that the right people have been prescribed adrenaline auto-injectors, that they know how to use them, that they know when to use them, and that they're not frightened about using them early. And I've got high hopes over time. It's not just going to be about adrenaline auto-injectors. We're already seeing on the horizon nasal adrenaline, sublingual adrenaline. So things that we know will take a lot of the anxiety about using adrenaline, because often people see it as this sort of nuclear option. They really don't want to use it either because they don't like needles, or they have to just accept, to themselves, I'm having a really bad reaction, I'm going to have to do something about it. Things are looking up on that front. We've also got whole new treatment modalities. I alluded earlier to the fact that you can treat it by avoiding, but now we've got options such as desensitization to food, which are becoming, a reality in our clinics. Biologics, a new range of medications that you can take that massively reduce your likelihood of having reactions to small amounts of the thing that you're allergic to, and those will just get better and better over time. a whole range of different ways of desensitizing people, not just eating it small, increasing amounts to become less sensitive, but applying patches to the skin, and other methods, sublingual, so squirting tiny amounts under the tongue. All of these are sort of a reality now, and increasingly so. This is a really rapidly evolving science. And I think the future is looking brighter than it ever has, certainly in the 20 years I've been involved in this. But you still have to get the basics right. And that means getting the correct diagnosis, getting good quality information that allows you to keep yourself safe, getting proper support from people who know what they're talking about through your allergy journey. And where it's necessary, having some psychological support as well, because it's completely normal to respond to all of this with with heightened anxiety. But you need support from somebody who understands allergy, not just understands anxiety. Because how can we expect a psychologist who doesn't know about food allergy to know how worried you should be about your food allergy? It needs a psychologist who understands food allergy, so they know what is appropriate and what is sort of nudging into pathology and needs addressing. And all of that's really important. And I'd love to say that's what kids get in the UK. It's not. I think, sadly, a lot of them are lucky to get even one component of that. But when it's done really, really well, it makes a huge difference to not just the outcomes in terms of the risk of reactions, but probably, even more importantly, the psychological well-being of those patients. Because, one of my sort of allergy heroes, there's a podcast, a guy, it's referred to as May Contain, and he's just documenting his travel around the world with his food allergies. And that's very much what I aspire to for my patients. I really want them taking part in absolutely everything. Yes, they've got to be sensible, and yes, they've got to accept that there are things that are going to be more difficult because of their food allergies, but that doesn't mean there's anything they shouldn't be doing. And I think that's a really great outlook. But you only get there with having a lot of support. It takes a village.
It really does, and I think it's so important to make sure that allergy sufferers understand that psychological element is real and also manageable with the right help and support. And thank you so much for joining me for this conversation, because I really
Pleasure.
appreciate how comprehensive it's been. I think it's going to be extremely useful to people.
Thank you very much for having me.
Thank you.